So welcome everyone. My name is Andrew Pinto. I'm a family physician and public health specialist and scientist working at the University of Toronto. I work clinically at the St. Mike's Family Health Team in downtown Toronto, and I serve as the director of the Upstream Lab. The Upstream Lab is a research team that focuses on three different areas: tackling the social determinants of health, artificial intelligence, and then clinical trials. And you can find out more about our work at our website, upstreamlab.org. And I'd encourage everyone to sign up for our newsletter that helps share a lot of the work that we're doing. We have a big team of over 40 staff and about a dozen graduate students and fellows doing lots of really interesting work. So please do follow along with our work. Where we're located and where the Upstream Lab is located in Toronto is on the traditional land of the Huron-Wendat, the Seneca, and most recently in the Mississaugas of the Credit. And we're very grateful to be here on this land. I think just to tie it into the topic today, of course, both Canada and Brazil are countries that experience colonization and that is still a very active process. And like many folks, listening in, I think that our lives have been shaped by colonization in many different ways. In fact, both, my family and my last name, show that I'm from a part of the world that was colonized by Portugal, as was Brazil. And so there's a shared kind of connection around colonization and how it influences us still today. So I'm really pleased to be joined here by Dr. Thiago Trindade. So Thiago is a practicing family physician and an assistant professor at the Department of Clinical Medicine at the Federal University of Rio Grande do Norte in Brazil. He's also an international faculty member of the Department of Family Community Medicine at University of Toronto. And he's the former president of the Brazilian Society of Family and Community Medicine. We're very, very fortunate to have him here with us at the Upstream Lab for the next year. He is, after completing a PhD and master's degree in epidemiology, he's now doing a postdoctoral research fellowship with us at the Upstream Lab. And he's going to be focusing his research around this idea of interventions that tackle the social determinants of health, and really bringing to us here lessons from Brazil and Latin America, and doing research to investigate this concept in Latin America, and also learning from what we're doing here in Canada. So I'm going to start by just asking Thiago to tell us a little bit about himself and a little bit of what brought you to the Upstream Lab.
Hi, Andrew. Thank you very much for inviting me for this speak series. I'm very happy to be here and doing my postdoctoral fellowship here. And hi, everyone who are attending for this speaking series. It's a pleasure to be here. So, speaking a little bit about me. So I'm a practicing family physician, as you just said, and a professor at my university in Brazil, Federal University of Rio Grande do Norte, where I've been practicing family physician at prime healthcare over these last 20 years. At some point doing research and teaching with medical students, residence students, and also master students in our university there. So during my training on research in my master and my PhD in Porto Alegre, I've been doing an epidemiology training background on quantitative studies. And my focus in that time were assessing health service and prime healthcare in Brazil and comparing different models and the outcomes on chronic disease. And by my practice, we have seen a lot of problems related to social care, and we've seen the limit of our practice in Brazil. So I started to get interested in how to tackle these kind of problems in our system, but looking to different experience around the world. And being here doing new research with Upstream Lab team, this fantastic team, and explore more possibilities. Just that what we have in Latin America and in Brazil and in Canada around interventions addressing social determinants of health in primary care settings. But of course, how we can go further, what kind of new experience and new innovations we can promote in the primary healthcare settings to really tackle these problems effectively in doing this integration between healthcare and social care. I think we really need this to rebuild and rethink our health systems to the old problems and to new problems that we have in this century. So that's why I'm very interested in doing new research and could bring to our countries new possibilities in those interventions.
Yeah, it's very interesting, and I think one of the people who I think both of us have learned a lot from in terms of like from a theoretical perspective. Just to start with is Paulo Freire, the really world famous Brazilian educator who helped introduce ideas about popular education, and famously wrote a book called Pedagogy of the Oppressed. And for a number of years, I taught an undergraduate course in essentially the social determinants of health at the University of Toronto. And I was always really mindful that I didn't want it to be a course where it was just about the facts and just about, okay, poverty is bad for your health. Not having housing is bad for your health. Food insecurity is bad for your health. So we actually started the course with Pedagogy of the Oppressed, and actually try to say that it's not like I'm the expert here and all of the students are empty vessels, as Freire kind of talks about it, and that tried to set it on the right path kind of from the very beginning, this type of class, to say like the students themselves have so much of knowledge, and through them I learned a huge amount about people's experiences, about living in social housing, of dealing with discrimination and the challenges of being in a university. So that's really, and I know that that's somebody who also has inspired your work. And maybe we could start with that. When you think of Paulo Freire and also other Brazilian kind of people who've really influenced kind of thinking, what comes to mind for you?
That's a good point. When we speak about our specialty in medicine, the family and community medicine, the second part is which kind of competence we really need to have in doing community medicine. And based on that, and during our training in Brazil, the expertise coming from the community is so important. So the lessons that we have learned from Paulo Freire expertise, it's very common in Brazil that we adapt those lessons to the health public interventions in the communities, doing what he taught us in the past. Listen to our communities, to their needs, learning with them, and construction a new knowledge that integrated the technical and popular knowledge. That's the basics of our approach in the community, not just as that old strategy that's just the health workers go there and doing some kind of speakers and teaching the community. No, how we can do the community approach very integrated, and the lessons from Paulo Freire is very important for us in Brazil as well. Other Brazilians as a well-known geographer, Milton Santos, who teach us how the territory movement really it's important for understanding the dynamic of the society in the territory. So it's one of our influences as well in the community health approach, and that's so important for when we are focused on the work in primary healthcare, really doing this embedded in the community and for communities, not just from the professional centered approach. That's really bothered me, and we have to move this kind of idea in primary healthcare to the person-centered approach and family-centered approach and community-centered approach. That's what really we can shift the way we work will be impact for the population.
Yeah, I think we're struggling with this right now here in Canada. Right now, there is a massive, kind of discussion happening about the future of primary care, because what we're witnessing is kind of the system collapsing around us, where every day almost in the news there's stories about family physicians burning out and retiring, tens of thousands of patients being left without primary care providers, people struggling to find primary care, and also the encroachment of for-profit entities who are really moving into this space and looking at a market to make money from. And so I think one of our, as people in research, often our kind of approach is often to say, well, we need to bring evidence to this, we need to inform policymakers, and I think there's a role in that. But I've really been thinking a lot about the role of the public itself, and the role of the public in pushing policymakers and pushing for this vision of universal access to primary care. So maybe we'll turn to that talk. I'd love if you just tell us a bit more about the Brazilian health system, because I think many people, including myself, don't have a full picture. What does it look like in Brazil?
Well, first we call our national health system the Brazilian acronym is SUS. That is Sistema Único de Saúde, Unified Health System. So I'll be calling this SUS. So the SUS was born with the federal constitution from 1988. It was built by a great grassroots social movements from the time that we were facing a 20 years military dictatorship. So this comes up from the feeling of the society that something have to change at that period, and a lot of social movements engaged in that from the scholars together that they call the sanitary reform movement. So during this 80s, this goes to a draft report from the National Health Conference of 1988 to the federal constitution. At that time, the Congress people from that time adapted that report, and it was the start legally of our health system. And in this new citizenship constitution that was called at that time, the health turned out to be a right and a responsibility of the state. And during the 90s, the system was implemented without new policies, and this is a tripartite managed system that the federal government promote the discussion of the strategy and the policies with the states and the municipalities who really deliver the service to the populations. And this all been constructed and discussed over the 30 years. So in the 90s, we have the implementation of the primary healthcare model that was born and was launched in 1994, the Family Health Program. That turns out to call it as a family health strategy that really, years later, that really turns out to be not just a government program, but really a state policy. That this is the basic of our public funded health system. We are very primary care oriented with these family health teams that we right now have over than 50,000 family health teams covering around 75% of Brazilian population. That is the total of our population right now is over than 200 million, and 75% of this population is really covered by these basic health teams that is compounded by a general practitioner that used to be a family physician, nurse practitioner, a nurse assistant, and the community health workers that vary the quantity depending on the families that we have for each team. That is around 1,000 families, or can be more or less than that, depending on the urban or rural areas. This is the basic of our structure and how it was being developing over these 3 decades. With a lot of graded outcomes that we have. Yeah,
that's a really helpful overview. So it's essentially comes out of a military dictatorship period that was from like the late 60s to the late 80s, and then emerges out of like the social movement pushing for a renewed health system, and now covers 75% of Brazil's population in these family health teams, which it's really incredible. Maybe you could tell us a bit about the community health workers, because I think that is a very unique aspect of the Brazilian health system, one which a lot of countries, including Canada, have looked at and thought, could this work here? But yeah, could you tell us a bit about the community health workers in these teams?
Yeah, it's excellent. And that's interesting in the history, because the program of community health workers was born previous of the family health strategy. It is started in a poor state of Northeast called Ceará, in rural remote areas, in areas that in that times in the late 80s didn't exist doctors available for those communities, and the government that recruit people from the communities to provide a variety of health interventions, especially in promotion of health and preventive disease, and all kind of intervention that could be held in the community by those people who really lives in that community. So this experience for Ceará, with a great results in that time, reducing infant mortality, the federal government in 1991 implemented this program. And in 1994, they became part of the family health teams. So every family health teams, we have those community health workers, and they're doing a very great job. Of course, during these 3 decades, we can see some kind of shift in their roles, and they became more specialized in some functions, but the main function of them is to help the people navigate in the system and doing this integration from the community and with family health workers of the teams. In doing this integration, not just in the regular use of the service, but basically bringing the all values and culture of the community to the health workers, works with cultural competence. I think this is so important for our way of work in Brazil. This is a concept from the principles of Barbara Stafford, work with cultural competence, but not even the primary health care workers are realized about that. So the community health workers has a role so important to bring this to our perspective in working and listen to the community and listen the needs of the population that really works by this link, doing home visits. So they provide home visit every month, not for every family, but especially for those really need more. And this specific task from that, doing this kind of linkage in with all different kind of health services that are provided by the team. Yeah.
It's and just to pick up on that that item that community health workers, they first of all they predated the family health teams, which is interesting. It does sound similar to other countries which in the 1970s and 1980s found themselves kind of having a huge increase in populations, but not having anywhere near enough kind of having professional physicians, and so engaging others. So in China, there was a whole movement around this. In other countries, there were movements as well, similar. And what you mentioned there was like these community health workers provide culturally competent care and act as a link to people in their homes. And in a similar way, I've had conversations with folks here in Canada that when family medicine was first started in this country in the late 80s and early 90s, one of the principles was that of being a resource to a defined community. And I remember talking with some of my my preceptors about this idea of even living in the community that you served, and how maybe historically that really was the case, that most physicians were living in the communities where their patients were and being very much integrated into it. And so then in the 1980s, 90s, and then onwards, with increasing austerity and neoliberalism, what we see is societies becoming much more stratified. And I would suspect that a lot of physicians don't necessarily live in the communities that they serve if they're serving particularly vulnerable populations. Now, that's not universal, but given differences in income and also the cost of housing, that creates this division. I know Brazil is kind of noteworthy for so many innovative ideas on many areas, but also it's a country with a lot of inequalities.
Yeah.
Maybe you could speak about that, because a colleague at a recent meeting in Latin America, kind of who is from Brazil, noted that Brazil is what perhaps the country with the greatest inequalities. How has that shaped the health system? And then we'll start to talk about kind of integrating social interventions as well. But what's your thoughts on inequity in a society?
Yeah. Yes, we really have one of the worst income distribution in Brazil. It's a very concentrated income and so few people. And the majority of our cities that we work, we see poverty in the great areas, and we have to tackle this every day. And the presence of the prime healthcare teams in the communities is a huge strategy of the government to really address these inequalities. We know that the presence and extension and in fact good quality primary healthcare teams can reduce inequalities. And we see that in our Brazilian research in primary healthcare, different research that have been published during these 3 decades show that how the presence of family health strategies can really tackle inequalities. And what I can see for us is that during the process of implementation of the system, equity is one of our principles that they are we have the 3 big principles in our constitution of our health system: universality, integrality, and equity. And since the beginning, the implementation of family health teams were prioritized to the most vulnerable population. So this increasing of family health team started in the most vulnerable. So it is the way we can impact during these years the most vulnerable populations, is to be there with good family health teams doing their practice there and helping people in all their needs, not just in health, regular needs.
Yeah, I think that is I want to kind of pick up on the point of one, that there is very good research from Brazil that that having this type of universal team-based primary care reduced inequities, and that's really powerful. But also that it's not only about the biological treatments, because I think a lot of people, when they think of the health system, if you ask like the typical person in Canada about what do you think, going to your family doctor or going to the health system is all about, they would say probably, well, I go if I'm sick, and I would expect like a medication or treatment or something like that. But what's, I think, a powerful idea is that potentially health and social systems can help people with determinants of health at both an individual level and potentially also at a whole population level. And of course, that's a lot about what we think about within the Upstream Lab is how can we accelerate this process? How can we tackle social factors at the individual level for individual patients, but also actually shape policies at a whole population level? Maybe I'll get you to tell us a bit about the Bolsa Familia program, which is, I think, one of the really unique programs in Brazil. And a very interesting kind of issue here in Canada is that we actually have rapidly increasing rates of food insecurity and people experiencing poverty with the higher costs of living since the pandemic and now ongoing. And we're actually the only wealthy country in the world here in Canada that doesn't have things like a universal school food program and things like that. But tell us a bit about Bolsa Familia. How did it come about? And what do you see as the role of this program in intersecting with the health setting?
Good. So the Bolsa Familia is a program that in this year is completing 20 years from its launch. So it's a cash transfer program to the families in poverty that was launched in 2000 years. And at that time, it was implemented step by step, and we have a lot of families right now receiving this. It is, we can see in the next years, it also probably could be a basics to a new program like universal basic income program. But for now, it's just for the most vulnerable in families in poverty. But the great this program is carried out by the Ministry of Development and Social Assistance, but is applied in conjunction with the Minister of Health and Minister of Education, because you have some conditionalities of the program to receive the cash transfer, to receive the Bolsa Familia program. The families must comply with some duties, like have the kids in the school, take the kids to the primary health care centers to have their immunization, to have their preventable care updated. So we work together, and it's very interesting because we have this data in the health system, and that show which families are most vulnerable, and which we can must be aware and provide more attention to those families in Bolsa Familia program. And for some families, it's just the only income that they have, and it's the way to provide food, and the way to provide the basic needs that they really are facing. So it's a very important program to tackle the basics needs for the population. And with the times, the program are being improving, of course, with other idea as training the parents for new employments and other kind of access for new incomes for them. If I would just want to remember beyond the Bolsa Familia, something that comes to me now. Remember, during this 30 years of implementation, I've been living this history since as I was a medical student. And the presence during the implementation of family health themes, when we get there in the communities, we discover a lot of families face that the state at that moment never figure out. So just the presence of family health teams doing visits, home visit to those families is a good way to we figure out what has happened and provide all kind of interventions. You can see families in completely social isolation from other neighborhoods. We can see families having their problem with food insecurity, and they, in some cases, they didn't even go to the healthcare centers based on the vulnerability and difficult to access the system. And the way we are present in the community is so important to open these doors for those families to access social care and health care.
That's a really wonderful image too. I really like the way you put it, of being present in the community and really helping families open doors to opportunities. You know, here in Canada, we really have not really anything like this. We have a small proportion of the population who are cared for by community health centers, which were set up mostly in the 1960s and 70s. And there is kind of a slow increase in them, but they are really unique where they are very community governed. And they do very good work at kind of a local area, but the vast majority of Canadians don't get care from that kind of model, and I don't think we haven't tapped into that. Interestingly, we are just on the start of doing research on what we're calling primary care districts for Canada, which would essentially envision a system where all Canadians are universally enrolled in a primary care system that's based on their geographic location, and everyone would be guaranteed the right to care, but also that there would be, as you put it, kind of a presence in communities. That and the parallel we're drawing in Canada is with schools. So right now we have school districts, and it's all publicly funded, and people are guaranteed access to education based on their local geography, with some modest choice as well between schools. But it's a system where parents don't have to worry about how do they get their kid a place in a school, and in the same way we are thinking about primary care. One of the other kind of interesting things is, like you mentioned, being present. So viewing our primary care centers as not only about delivering biological treatments or even individual level social care, but also being centers for that community in the same way that, say, schools or public libraries or community centers can be centers. It can lead to things like civic engagement in a way that's not happening right now. And in addition, by creating districts, we're hoping we could move to a model where people actually elect trustees to their local primary care district in the same way we elect school board trustees. So we're a long ways away from this, but it's definitely inspired in part by ideas like what Brazil has done. And I would say there's a few other countries like in Latin America that have also imagined and worked on this type of systems. Two that come to mind would be Cuba and Costa Rica. And I know that there are others. Maybe we'll turn to your goals around research over the coming year, and what makes you excited about this, and then we'll kind of turn to the group here for questions.
Yeah, just to say now, I think Canada has a great experience in prime healthcare, and also all this model of district school board is really a good example of how to implement this in primary care. Isn't the idea of have a catchment area and the community, the responsibility for determined areas and populations is so important, not just for education but for health too. And I hope we can see this in Canada in coming years. So about my perspective on research, I'm very excited to go on, and firstly, we are doing a scoping review to map, to figure out what intervention we are really doing in Latin America countries address social determinants of health. In the primary care settings, on the ground, that we can really learn for those experiences. We do a lot, and if we didn't do this kind of research, mapping this, gathering this new knowledge for the policymakers, we can go ahead. So, and the idea is to identify also the gaps that can guide us for future research. And at the same moment, we have other projects that we need to address the policymakers and the healthcare leaders in Brazil, the barriers, what the facilitators that we can see in the system, how to address social issues in primary care settings is one of our ideas in with a qualitative study. And now I'm also engaged in other trial here in Canada that's just starting, the SPARK trial, that will be an intervention with community health workers, and we'll be training to provide intervention to patients in population who are deserving some kind of guide in their social needs. And so this is just the beginning of this research training here, but I hope in the future we can really build a research team in my university in partnership with University of Toronto, with Upstream Lab, that we can continue to provide new interventions to really have a new perspective for our health system that really can integrate this health and social care in a very strong way to tackle this problem and not to be fragmented as we have right now in the majority of countries. So that's this perspective, and looking for those in our countries, and goes on with new innovation to the health systems in an upstream way.
I'm so delighted that you're with us for this year. I know we're already learning so much from you, Thiago, and it's really neat to see your plan around understanding how countries across Latin America are integrating health and social care. What are barriers, to implementing this in Brazil, and also being involved in a trial here, kind of from the start, which hopefully is a really good experience as well. I want to thank you so much. This was really, really fantastic. And yeah, look forward to following your work. So we're going to now turn to questions that folks have posed, and please, to everyone who's joining us, feel free to put questions in the Q&A. We have a great question just to start, which was, what about some practical considerations with the SUS system? Like, as you know, can a lower middle class rely on it? What's the quality? And of course, in Brazil, there's a private health sector where more wealthy people can pay. What does it look like? And are there wait times? Is there lower quality in the SUS system?
A good question that Paulo brings us. Is important that we can discuss this a little bit further. That we have this private practice in Brazil that we call a supplemental health, like 25% of Brazilian population have some kind of private insurance, and those is just basically for medical care. This kind of private insurance doesn't provide other broad health service like pharmacare, like immunization, nothing like that. Not even other kind of emergency care like ambulance or other things. So it's very basic for health needs on medical care. So what we've seen is really the middle class and high middle class use this service more, but they use also the SUS. And we've seen this during pandemic and post-pandemic times, how it was acknowledged by the society, the presence of SUS, and how this really be preserved and enhanced as a national asset. So the capacity of the national health system to do surveillance, to provide strategy even to the private sector and monitorize the private sector to provide good service, and also provide a range of services that are not provided in other sectors. So what we need to do is, of course, get better our facilities in public, to bring more people to use the service, and have this as defending and standing for everybody in the country who really needs and can and have this as a proud, for example, for the UK citizens, that the NHS is a proud for them. We need to develop this feeling in the society, and everybody could gather in this proposal.
Yeah.
But how we really have some problems relating to waiting times, and for secondary care, we have some problems that it's a historical issue that in Brazil our health system is still underfunded. Our expenditures in public system is just around 4.5% of GDP. So we need to expand our budget and health, and get all the levels of the system for a high level service, that everybody can have this in their.
It's a really interesting question too that comes up with a lot of others. Some other colleagues in the Upstream Lab are doing work on India as well, and the role of the private sector in kind of sapping people and resources away from the public sector. So there's often that issue where, you know, essentially there's only a fixed number of health providers, and so with the private sector, it can draw people away from the public sector in terms of health human resources. There's a couple of good questions, just kind of quick ones. You know, one is around the role of the community health worker in terms of the question was kind of, can they refer back to primary care? I think your point was that they are integrated in the primary care team. They're not like off to the side, right? They're part of the primary care team. And then there's a related question of, are physicians recruited and trained in the communities, and do they stay there? Or is it really that most physicians are coming from outside of the community and don't live there?
Yeah, looking to this question related for recruitment of physician, we have some research in Brazil that in the last 10 years we expanded the medical school to rural and remote areas in Brazil. And that was very interesting, because when you go there, not just open new medical school, but open resident programs, you can see those people from the community that enter in medical school and go to the residence training. They tend to stay in that local, that site, after the residence training. So that's a good way. It's to recruit people from the community, is to have medical school and residence programs there. That's a way you can really retain this healthcare workers, and that's a problem around the world, related to rural and remote areas.
Yeah, just to pick up on that before going to the other question, here in Canada, the same challenge, it's partly why we created in Ontario the Northern Ontario School of Medicine, was specifically to recruit and train people in northern and rural communities. And my understanding of the research is that it's been successful in part to help increase the number of physicians in northern Ontario and rural areas. The other interesting, very recent development is here in the Toronto area. We're actually starting new medical schools that are specifically in areas like Brampton, which is a city that's kind of to the northwest of the main part of Toronto, and opening a new campus of the University of Toronto School of Medicine in Scarborough, which is also an underserved area. So there's a movement to really train and recruit people from underserved communities. And then I think we'll need to follow this to see if it's successful, because I think sometimes if we don't also put in place the supports to people, then they tend to come back to where the kind of middle and upper income groups are. So there's like a real need to make sure people are supported too, like they have all the infrastructure to be successful in primary care in those areas. So there is a question about community health workers. Could you just explain how are they part of the primary care team already? What does that are there and there was this question of like how do they communicate with other members of the team?
Yes, they are completely part of the team. They are hired by the municipality government and have their salaries as a health worker, and it's part of this basic income teams. Basic because you have the basic prime healthcare team and the support prime healthcare team. So this part of the basic. We have at least around 4 community health workers doing part of this team and working everyday basis in the healthcare centers and doing home visits and have meetings with the teams and discussion each case of family and patients with them. It's so important to have them as a health worker. And of course, during these years, we have new acts and law that regulated as a profession in Brazil, and they are unionized and says very strong as political actors in Brazil.
We're kind of, I think, coming to the end of our time, and also for others, if you'd like to put questions, please do. I'm gonna maybe end with a question that is about population health. And this is something that both you and I are really interested in, which is what is the potential for these primary care teams in advancing essential public health functions and improving population health. You mentioned a bit about the ability to go into communities to identify issues. Maybe you could speak a bit more about that. I'm quite interested in disease surveillance, and the fact that now we're actually doing some research at the Upstream Lab around using artificial intelligence to process electronic health records to do surveillance in a real-time fashion, not 6 months later, but actually every single day. We're also doing work around constructing a system across Canada that would help us prepare for the next pandemic and be able to detect it early and engage primary care in that. But what's your thoughts on how can primary care systems support public health?
Yeah, that's a good question. I think we need to advance a lot on this, and I think electronic medical records with artificial intelligence could help a lot. But even without that, we have a historic in Brazil that since the beginning of the private healthcare teams, we worked without electronic medical records in the 90s, and we did at that time in 2000, of course, also health surveillance with paper, with sheets, and with notice, and of course with maps drawing where the people are, and I think of course when we have those data processed, the electronic is much better, but I think when we do this as principle of our work, because at some times the primary healthcare teams just thinking that their roles is to see patients and not communicate and say that it's part of our responsibility, their surveillance as a team, and provide also strategies. We deal with a lot of neglected disease in Brazil in our community, like arbovirus, dengue, as tuberculosis, as leprosy, as malaria in the north. So as part of our job doing this, and there is no a possibility to separate the primary care teams and the public health. We must work together, and the community health workers, and even we have other professions that the community workers on endemics disease, they work together as well in the primary care level.
Yeah, I very much agree with that. I'm a big fan of the potential that really robust universal primary care has to help advance public health. So I just want to bring it to a close. Thank you so much, Thiago, for joining us and for sharing your experience and your thoughts. And really excited to really follow your work and to be a collaborator with you on all of it and support you. And thank you everybody for joining us today. I hope that you'll be able to join us for future Upstream Lab Speaker Series events. Take care.